So good evening, everybody. I'm Dr. Amit Desai, and today we will start gastroenterology part 1, where we'll start with dyspepsia, dysphagia, and then some esophageal disorders of the upper GI tract problems, and then we will go on to GI bleed, okay, upper and lower GI bleed. This is our plan for the day, all right? Now, uh, when we look at the various disorders, we'll be seeing dysphagia, dyspepsia, as we said. We'll be seeing an important disorder which we see very often clinically, and that is known as GERD or GORD, that is gastroesophageal reflux disease. All right. And something called as hiatus hernia. So if you spell esophagus with an O, you call it GORD. If you spell the esophagus with E, you call it GERD. Then we see another common disorder, which is peptic ulcer disease. Then we see diarrhea, which is commonly seen. We'll see inflammatory bowel disease, most probably we'll be seeing next time, diverticular disease. All the colorectal problems we'll be seeing next time. We'll be seeing bleeding this time, along with liver cirrhosis, which causes a type of bleeding called as variceal bleed. Esophageal varices and variceal bleed is something which we see in cases of liver cirrhosis. And then we will see intestinal obstruction again next time, anorectal diseases, and then we go to hepatobiliary and pancreatic diseases along with her. Okay, so we have a large agenda. Within 3 lectures, we'll try to cover everything possible. All right. So let us start with what is known as dyspepsia. What do we mean by dyspepsia? Okay, it's a vague thing. It can mean either of these two things. Either it can mean epigastric discomfort or pain. It can either mean epigastric discomfort or pain, or it can even mean postprandial bloating of the abdomen. Postprandial bloating of the abdomen. So any of these two can be called as dyspepsia. Why do we combine them or take them together? Because many a times, most often we see that the causes of either of these are more or less similar. Now, what we need to understand is the first and foremost thing, and that is alert symptoms. What is it in a dyspepsia that should be a red flag for us? Now, why are we talking about this? See, when you start seeing patients, especially if you're sitting in a GI OPD or a general surgery OPD or even medicine OPD for that matter, you will see a lot of patients which present with epigastric discomfort or pain, some of them presenting with postprandial bloating. Now, even if you look, if you think for some time, you will realize that sometime in your life, maybe 3 or 4 times in your life, you have got these symptoms yourself. Okay, so these are something which are very common, and a range or plethora of causes can cause these, all right? Most of these causes are all benign, or most of them are functional, most of them are benign. But then there are certain things which are red flags, which we should not miss, because that tells us that this could be something dangerous. So what is it that we will look out for? Okay. So if you look out for the history, in history, first and foremost, the age which is more than 55 years. All right. Another thing that you will see is recent onset of daily pain. What else can be there? There can be vomiting. There can be dysphagia, or even upper GI bleeding. This is something which you should take very seriously. Somebody is telling that there is dysphagia, one person cannot swallow if the food is getting caught somewhere. That is something which we have to bother. Constant vomiting, long-term vomiting. Then if there is a history of non-steroidal anti-inflammatories, you will realize that many of these problems are precipitated by non-steroidal anti-inflammatories. If there is a history of unintended and rapid weight loss, significant weight loss, somebody losing almost 10% of their body weight within 2 or 3 months, which is unintended. Okay. So if a person is undergoing weight loss, for some specific purpose, that person is going a weight loss program, dieting, going to gym, doing exercise, and then that person has weight loss, it's a different thing because it's an intended weight loss. But if there is a significant weight loss, that is almost 10% of the body weight within 3 months, which is unintended, then that is something which is a red flag for us. Then we will look out for past history. Past history. In past history, we will see history of gastric ulcer or gastric surgery. This is something which is something which is alarming. On examination, if we see that there is anemia, or if we see that there is an epigastric mass, again alarming for us. Epigastric mass, again alarming for us. So these are things that we should look out for. The moment a person comes to us with dyspepsia, and what do we mean by dyspepsia? Either epigastric pain or discomfort, or postprandial bloating, that is bloating of the abdomen after food, then that is dyspepsia. The moment you have a patient of dyspepsia, the first thing that you should do is look out for these alert symptoms. And what are these alert symptoms? 8 things in history, 2 things in past history, 2 things in examination. Okay, 8 things in history: the age, the onset, the type of pain. Okay, the age, the type of pain, the onset, the vomiting, the dysphagia, the upper GI bleed, history of non-steroidal anti-inflammatories, history of weight loss. Okay, these are the history things that we will see. Past history: gastric ulcer, gastric surgery, anemia, epigastric mass. All these are alert symptoms. All right, alert symptoms. All right. Now, why is this important? Because if these alert symptoms are not there, then you should not, go ahead with a lot of testing. Rather, you can start directly with anti-secretory drugs. What are anti-secretory drugs? They are also called as proton pump inhibitors. What do you mean by proton pump inhibitors? Hydrogen potassium ATPase pump inhibitors. These are called as proton pump inhibitors. All right, you can start with them. Also, depending upon what is the likelihood of this person having H. pylori, you can even do H. pylori testing. Okay, so we will see the algorithm later on, but you must remember that the moment a person comes with dyspepsia, first thing is alert symptoms. If alert symptoms are there, you follow a different algorithm. All right, because important things that you have to look out for. You can look out for gallbladder, you'll have to look out for pancreas, and you'll have to look out for liver in case there is a alert symptoms. You may even have to do an upper GI endoscopy if there are alert symptoms. All right. So now let us take this question. So a 35-year-old patient presents to your clinic. 35, male, female, they've yet to say, with a history of epigastric discomfort for the past 12 months. Discomfort is burning in nature and does not radiate up to the chest or anywhere else, and lasts for 30 minutes to a few hours. It is temporarily relieved by antacids. The discomfort does not wake him. He means it must be a male from sleep, is unrelated to exertion, and has inconsistent relationship to eating. John says he has experienced significant emotional stress since losing his job as an executive at a merchant bank 5 months ago. Pain is worse during stressful days. He has no regular medication, denies NSAIDs or family history of GI disease. He's a non-smoker, drinks approximately 4 alcoholic drinks per day. So now my first question is it dyspepsia? Do we all agree that this is dyspepsia? Yes or no? Yes, very good. Now, my second question is that once we say dyspepsia, does he have any of the alarm features? Does he have any of the alarm features? No, so he does not have any alarm features. All right. So that means that we don't have to bother. So that endoscopy as a first step goes out there and then. All right. Now, endoscopy as a first feature goes out there and then. That's right. That's right. Okay. The answer also that I'm getting is correct. Okay. You don't have to do H. pylori immediately. Okay, don't have to do H. pylori immediately. So what our algorithm says that you start PPIs, but before PPIs, it is better you educate the person and give lifestyle modification. So B is the answer. Educate the person and give lifestyle modification. Okay, so that is the first and foremost thing. And if that is not doing things, then it is better to do the start PPIs, anti-secretory. So the first thing that you would do is education and lifestyle modification. So what you will say, you will ask the person, you will standard, everyone gives standard advice, reduce weight, stop smoking, stop alcohol, avoid fatty foods, avoid coffee, tea, chocolates, all right, avoid alcohol at night, avoid gaseous drinks, that is the colas and sodas kind of stuff. Okay, at least 3 hours between evening meal and retiring. In case you know better than me, or no fibrous food, chew your meal properly. Nowadays, you have classes, people teach you 1 day course on how to chew. There are 1 day courses on how to breathe. So there are a lot of things, we all know all these things. Okay, sleep on the left side. That is also one thing. Avoid spicy food, tomato products, and all these things. Avoid certain drugs. Okay, avoid certain drugs. All right, then you can give antacids. Okay, you can give antacids. Avoiding drugs, these are the first line mein jo diya hai, that those are the drugs which should be avoided. Doxycycline, calcium channel blockers. Why calcium channel blockers? Because they will make the sphincter lax. All right, that thing, non-steroidal, etc. Then if things are not getting better, then you will start with PPIs, omeprazole. If you think that it is H. pylori, you can start with triple therapy. Then you will give for 4 weeks. Then you will review with urea breath test. Okay, if there is an ulcer or if there is persistence or something like this. Now, next question. 44-year-old woman comes to you because of pain in the epigastric area for several months. She denies nausea, vomiting, weight loss, or blood in her stool. On physical examination, you find no abnormalities. What is the diagnosis? The first question that we ask, is it dyspepsia? And I think the answer is yes. Second question, are there any alarm symptoms? Are there any alarm symptoms? No. So there are no alarm symptoms, right? So since there are no alarm symptoms, I think you can rule out pancreatitis. You can rule out gastric and duodenal ulcer disease. Now the question is between gastritis and non-ulcer dyspepsia. Frankly speaking, this question is very dicey because it can be gastritis also, it can be non-ulcer dyspepsia also. But the more benign out of the two is non-ulcer dyspepsia. That is why we can think that this is non-ulcer dyspepsia. All right. Now, that's why non-ulcer dyspepsia. Why it is not gastritis? If you ask me this question or if you put it during your Discord, why is it not gastritis? I will not be able to answer you because this can very well be gastritis. So this is a dicey question, remember. But out of the two, yes, non-ulcer dyspepsia is slightly more benign. So what they want to indicate is which is the more benign problem out of the lot. All right, so this is. Now, what are the peculiarities of a gastric ulcer? Pain increases with food. So what happens is, gastric ulcer versus duodenal ulcer, if you see, in gastric ulcer, pain increases with food. Why does this happen? See, in our body, since stomach has acid, there are certain mucosal defense mechanisms which are provided for the stomach. That is the reason why the acid is there. Okay. So imagine, you are in a chemical factory where they are producing acid. So the tanks in which they are kept, they are naturally made up of such material that the acid will be retained. Okay. They are not going to be made up of material which is going to be corroded by acid easily. Similarly, our stomach has got mechanisms, the mucosal secretions and thick layer and all these things to take care of the acid. So what happens is when these barriers are low, when the mucosal defense mechanism is broken, that is the time when gastric ulcer takes place. All right. So in gastric ulcer, you will see most of the times there is hypochlorhydria or achlorhydria, which means that the actual acid production is less, but the ulcer is basically because of the mucosal defense mechanisms going wrong. Whereas in duodenal ulcer, it is usually because of hypersecretion of acids. Okay, it is because of hypersecretion of acid. So when you eat food, what happens is in stomach ulcer, what happens is that that food irritates that area and there is pain. Whereas in duodenal ulcer, what happens is that the food neutralizes the acid and that is why the pain decreases. So you will see that a person with gastric ulcer will eat less food, whereas the person with duodenal ulcer will eat more food. Why the person will eat more food? Because that food neutralizes and there is no pain. So there is weight gain in a person with duodenal ulcer, whereas there is weight loss in a person with gastric ulcer. So that is one thing. Okay. Significant weight loss you will see even with cancer. Tenderness in pancreatitis. Epigastric tenderness radiates to the back. The pain radiates to the back in pancreatitis. Can anybody tell me why the pain radiates to the back in pancreatitis? Any reason? Why the pain radiates to the back in the pancreatitis? Any reason why the pain radiates to the back in pancreatitis? It is something to do with the anatomy of the pancreas. Where is the pancreas? What is that space where pancreas is located? What is that called? That's right. That's right. So pancreas is retroperitoneal. That's why the pain radiates to the back. Okay. Pancreas is retroperitoneal. That is why the pain radiates to the back. Very right. Absolutely right. Now let us see dysphagia. What is dysphagia? Dysphagia. And there is another thing called as odynophagia. There is something called as dysphagia and there is something called as odynophagia. Dysphagia is inability to swallow. Dysphagia is inability to swallow. Whereas odynophagia is painful swallowing. This is usually secondary to inflammations and infections. So if there is a fungal infection or something of that sort, HIV or even herpes esophagitis, all these things, esophagitis usually causes odynophagia. And dysphagia is inability to swallow. So it can be due to benign causes like, there might be webs, there can be web formation, stricture formation, etc. They can even be secondary to malignancy or something pressing upon. Okay. For example, when the left atrium increases in size, it presses upon the esophagus. This is seen in your mitral stenosis. It just presses upon. Now, when we talk about dysphagia, there are two things in dysphagia. One is something called as oropharyngeal dysphagia, and the other one is the esophageal dysphagia. Now remember, for looking at this, we have to see swallowing. Swallowing reflex, if you see, has two parts. One is the voluntary part and the other is the involuntary part. The voluntary part usually takes place in the pharynx, whereas involuntary part takes place in the esophagus. Once it is into the esophagus, what happens is that the bolus of food is going to go down. You don't have much control over it. If you look at the esophagus, there are two types of muscles that it has. Skeletal muscle, which is voluntary, and the other type of muscle is the smooth muscle, which is involuntary. So the skeletal muscle is going to be more at the top. Okay, and as you go down the esophagus, the skeletal muscle goes on becoming lesser and lesser. And the smooth muscle is more at the bottom. So in the upper part, you will hardly have any smooth muscle, and lower down, there will be only smooth muscle. So what happens is that as the swallowing takes place, there's first the voluntary phase, and then there is the involuntary phase. So the upper part of the esophagus and the pharynx are responsible for the voluntary phase, and the lower part of the esophagus with the smooth muscle, where there's peristalsis, is responsible for the involuntary phase. All right. So that is why we have two distinct type of dysphagias. One is oropharyngeal, which affects the voluntary phase, and the esophageal, which affects the involuntary phase. And this is more often neuromuscular in nature. So it is secondary to neurological disorders and muscular disorders. All right. So dysphagia is difficulty in swallowing. What do we swallow? We swallow either solids, fluids, or saliva. These are the three important things that we swallow. All right. Now, oropharyngeal dysphagia, as we said, is neurological deficits. Okay. And they're usually clinical manifestation of some underlying disease. So there might be motor neuron disease, some other disease, some paralysis, and that can cause this. Whereas esophageal dysphagia is usually obstructive lesions or localized neuromuscular problems. All right. So one has to be more careful. So if you're looking at oropharyngeal, there will be difficulty in initiating a swallow because the voluntary phase is affected. All right. And because there might be paralysis of the palate and all, there might be nasal regurgitation. Food sticks higher up, not below, higher up. There might even be coughing, choking, drooling, other neurological things like diplopia, dysarthria, recurrent pneumonia, weight loss, etc., etc., etc. Whereas the features of esophageal dysphagia will be food sticking in the throat or upper chest, okay? Several seconds after swallowing, not immediately on swallowing, after swallowing, all right? And somewhere below or behind the sternum, here there will be, the food will get stuck. There might be heartburn, there might be other things, okay? Now, what are the red flags over here? Red flags or alarm symptoms that you should be careful of. Short duration, again over there also, no? Short duration, rapid progression of symptoms. Dysphagia more for solids than liquids, weight loss, and anemia. These are the important things that we should look out for. Remember, clinical history is important for differentiating between oropharyngeal and esophageal dysphagia. Contrast swallow and endoscopy can be done. VFSS and FEAS, these are the video swallowing studies that are done, functional esophageal swallowing studies and video swallowing studies, which can be done for oropharyngeal dysphagia. Now, if you cannot find any reason, then it could be functional dysphagia or functional disorder. So there is something called as Rome 3 classification, which tells us, whether we are dealing with something which is functional. So if you remember when we talked about dyspepsia also, if you couldn't find anything, if you couldn't treat anything, then at the end of the day, you would say that it is functional. Okay, so similarly over here, if you can't find any other reason, then it is functional. Let us go to 𝗙𝗘𝗃𝗃. Now, before we see 𝗙𝗃𝗃𝗃, there are certain things that we must know about. One is we must know about the enteric nervous system. Okay, so there is mucosa, there is submucosa, there is muscularis. Now, remember in GI tract, the outer covering, uh, can either, this is mucosa, this is submucosa, this is the muscle layer, muscularis. Now in GI tract, The outer layer can either be serosa or it can be adventitia. Now, what is the difference between the two? Serosa is when there is peritoneum. When there is peritoneum, when the organ has peritoneum outside, it is called as serosa. Where there is no peritoneum, it is called as adventitia. All right. Now, there are two types of nervous systems. Okay. Enteric nervous system has two components. Enteric nervous system has two components. There are certain nerve plexuses which are present in the muscle, and there are certain nerve plexuses which are present in the submucosal. So this is the submucosal plexus, which is also called as Meissner's plexus. And it is responsible for secretion of glands. Whereas this plexus is the myenteric plexus, which means that it is in the muscle. All right. It is also called as Orbach's plexus. And it is responsible for peristalsis. It is responsible for peristalsis. Now, when we are talking about peristalsis, there are two distinct movements in peristalsis. One is contraction and one is relaxation. Now, you will tell me that what is so great about it? What do you mean by two distinct movements? Even if I'm contracting my hand, okay, there is contraction and relaxation. That's right. But what happens is that when we are skeletal muscle, what happens? There is only one thing. Okay, when we are contracting, the contracting muscle is contracting. Okay, you don't have, and by default, the opposite muscle is relaxing. You don't have to give different order to the opposite muscle to relax. Okay, and there is only one neurotransmitter. But in peristalsis, you have to give a separate order. The nerve has to give separate neurotransmitter for contraction and special neurotransmitter for relaxation. Because unless you give neurotransmitter for relaxation, relaxation will not happen. So what is the neurotransmitter for contraction? It is acetylcholine. Whereas for relaxation, there are two neurotransmitters. One is nitric oxide and the other is VIP, vasoactive intestinal polypeptide. Nitric oxide. What is this? This is acetylcholine. All right. Now, what happens is that 𝗙𝗕𝗂𝗃𝗃 is a condition in which the ganglia which produce these neurotransmitters, they are destroyed. 𝗙𝗕𝗂𝗃𝗃 is a condition in which the ganglia which produce nitric oxide and VIP, that is the relaxing neurotransmitters, are destroyed, as a result of which two things happen. What happens? Number one is you get non-relaxing lower esophageal sphincter. And the second thing that you get is absent peristalsis. Now let's go to ulcerative esophagitis. As the name suggests, esophagitis, that means there is inflammation of the esophagus. But along with that, there is also erosions and ulcerations. Now, what do we mean by erosions? Erosions means only the superficial part, just the mucosa, which is broken up. Whereas ulceration means a deeper injury, that is what happens. So ulcerative esophagitis, various causes could be chemicals. Some person having, certain chemicals, because of that, it could happen acids, alkalis, could be due to ionizing radiations, batteries, heat, very hot liquids. Okay, these cause mucosal injury, and basically what happens is that injury causes, there's inflammation, and inflammation is many a times followed by fibrosis. Okay, heals by fibrosis. So that is why this can cause pictures also. All right. So acutely, there will be reddening of the mucosa. But what happens is that if it is more severe, for example, acid or alkaline especially, it will give rise to liquefactive necrosis. And because of that, what will happen is that inflammation gives rise to fibrosis. Okay, healing is by fibrosis, and there can be stricture or stenosis giving rise to reflux esophagitis also. You will ask me why reflux? Because as we know, if there is longitudinal scarring, there will be shortening of the esophagus. And we have already seen that if the abdominal esophagus becomes shorter, the chances of reflux are more. Right? So how do you investigate? Investigation by endoscopy. Control acidity by using H2 receptor blockers, or more often what we use is PPIs. Okay. And mucosal protection can also be used. Now, let us go to diarrhea. These are the various causes of diarrhea, malabsorption, giardiasis, etc. There is something called as a functional type of diarrhea called as irritable bowel syndrome, where the patient has abdominal pain or discomfort occurring at least 3 days per month for the last 3 months and associated with at least two of the following. So 3 days per month for at least 3 months plus two out of the three. What is the two out of the three? The moment person goes to defecation, the person feels better. Okay. When the symptoms happen, there is a change in bowel frequency. So either the person will have diarrhea or constipation, and there will be change in the stool appearance. So when the symptoms happen, either there will be diarrhea or constipation. That means the frequency will change, the appearance of stool will change, and after defecation, there will be improvement in symptoms. Okay, so these are the criteria which help us to diagnose irritable bowel syndrome, which is a functional cause of diarrhea. Functional. So abdominal pain with change in bowel habit for an extended period of symptoms. So there might be fecal urgency, especially after meals. Every time the person has a meal, person needs to go. Person may have to strain while passing stool, incomplete evacuation, abdominal bloating, passing of mucus. Okay, that is also possible. So minimal investigations are required. Okay. So you must look out for red flags. Look out for red flags. So if there is bleeding or something of that sort, then these are red flags that you should look out for. You endoscopy, if you do, it's not going to yield you much. You must do a full blood count, celiac serology to rule out celiac disease, C-reactive protein to rule out inflammation. All right, and fecal calprotectin. Now, fecal calprotectin is basically for inflammatory bowel disease. So tomorrow or next time we will talk about something called as inflammatory bowel disease, where there is inflammation. Okay, and there are two things, ulcerative colitis and Crohn's disease. There is also a third one called indeterminate type. Okay, so these are the things that are inflammatory bowel disease. That's a different ball game altogether. All right. Now, if you find that a person is IBS, reassure the patient. Don't worry. Okay, these things are going to be all right. Many a times it is related to psychological health, gut microbiota, biota, or hypersensitivity. Okay, so as and how you have to treat the person, you have to first improve the diet. There is something called as a low FODMAP diet, okay, where fermentable oligosaccharides, disaccharides, monosaccharides, and polyols have to be given low. Okay, you must try to avoid these. You must give more and more fibers, but avoid wheat bran and large quantity of insoluble fibers. That is also important. There are two types of fibers. There are insoluble and soluble fibers. Okay, that help.